This is Francisco Ponce, and I'm the program director of the Neurosurgery Residency at Barrow Neurological Institute. You are listening to Interview with a Surgeon with a Surgeon Agent.
On this episode of Interview with the Surgeon, we welcome Dr. Francisco Ponce, neurosurgeon and the chief of stereotactic and functional neurosurgery at Barrow Neurological Institute. He serves as director of both the Center of Neuromodulation and the Neurosurgery Residency program. Dr. Ponce's experience includes deep brain stimulation surgery for Parkinson's disease, essential tremor, and dystonia. He is also active in the operative management of cranial and spinal trauma. Dr. Ponce has published extensively on DBS and other neurosurgical procedures in peer-reviewed journals. He presents regularly at national and international conferences.
Hello, everyone, and thank you for joining Interview with the Surgeon. Today, we welcome Dr. Francisco Ponce, neurosurgeon at Barrow Neurological Institute. Doc, how are we doing today?
Always great. Thanks for having me, Matthew.
Thanks for being with us. So let's just jump right into it. What were your goals and aspirations during your residency, and how did those change during your fellowship?
So going into residency, with surgery, right, there's an apprenticeship model, right? It's an apprenticeship. You learn. There's varying degrees of exceptionalism amongst surgeons. So going into residency, I knew it mattered who I trained under, and I wanted to train under a master surgeon. And at that time, Robert Spetzler was like the biggest name in neurosurgery. It's one of those that, once you start digging, you discover that there's this surgeon in Phoenix, Arizona, who's doing things that nobody's doing. And so I really sought out that opportunity to kind of kickstart and get the foundation of my essence as a surgeon rock solid by training at the best training program there is. And what was really kind of the metric there was these very complicated surgeries involving aneurysms, sort of the pinnacle of technical difficulty in neurosurgery. Neurosurgery kind of represents the pinnacle of medicine, and on top of that, the aneurysm surgeons, the ones who kind of clip these ticking time bombs, have kind of had this position in neurosurgery as sort of the top dogs since the 1970s, the most dangerous and technically demanding operations. And so I sought that out, and I went in, I did some brain tumor research as a medical student, but by the time I started residency, I had done a number of clinical research projects, had kind of gotten under the wing of Dr. Spetzler, and kind of envisioned myself being his protege. During residency, I realized that, kind of to quote Wayne Gretzky, right? You want to skate to where the puck's going, not to where the puck is. That there was sort of a change occurring in neurosurgery. And what was the great surgeries in the 1980s were not going to be the great surgeries in my later career, even when I started my career after residency. And it was funny because actually one of your previous guests, John Adler, he was the first neurosurgeon I interacted with right after I graduated from undergraduate, from college. And he, as I was applying for residency 4 years later, he kind of gave me some advice that the aneurysm surgeons were going to be the dinosaurs, and that technical mastery that requires those 10,000 hours of deliberate surgical practice, that this skill set was going to be something that was going to kind of fade as medicine progresses. And that kind of stayed in the back of my mind. And so during residency, I kind of saw that all the chairmen, who themselves were tumor surgeons and aneurysm surgeons, would say the future of neurosurgery is functional. That's basically rewiring the circuits of the brain to treat various conditions, Parkinson's, tremor, we're looking at Alzheimer's, depression. But that operation, that is not a very technical operation. Basically, drill a hole in the head, and then you pass a wire to the spot that's going to, pace the brain. And it was not as sexy, right? And at Barrow, which we beat our chest being the most technically gifted, training program in the country, people traditionally weren't going in that direction. And so during my residency, as I was kind of like surveying the changing times of of medicine and surgery and where things were headed. The unique thing about functional neurosurgery was what it sounded like to the public. You know, the ability to capture the public's imagination, saying, we're going after Alzheimer's by turning the light bulb back on, you know, and the visual effect of turning on a deep brain stimulator and seeing a significant tremor disappear. And so there's a discrepancy between sort of what you experience in the operating room and what you actually see from the outside, you know, these amazing outcomes and really like the imagination, the possibility of these brain machine interfaces revolutionizing how we restore function for patients. And it was a buddy of mine in college when I met up with him discussing clipping an aneurysm, and we were both physics majors in college. And it was the appeal of clipping an aneurysm was completely lost on him, right? It's like you can train a monkey to operate. And that was a moment that occurred about halfway through my residency as I was kind of getting other kind of influences in terms of kind of where I should be skating. When you talk about functional neurosurgery, it sounds really cool. But in residency, you usually see like the first and second year residents doing it, not the seventh year residents. You don't do 7 years of training to drill a little hole and put a wire in the brain. And so that was sort of really where I kind of said, you know, somebody's going to do it from Barrow. It might as well be me. You know, everyone's saying this is the future. You know, the conventional wisdom is sort of like this clipping of aneurysms may be the thing of the past. And as much fun as it is to get under the microscope and get your hands into the center of the brain and do very delicate work like our Dr. Spetzler or Dr. Lawton, you know, I figured, you know, give this a shot, see where it goes. And that was the biggest pivot, I think, in my residency was deciding to kind of put my subspecialty interest in that direction to kind of be ready if a position like that were to open to seize that opportunity.
So taking us through your mentality during your fellowship, what were you going through regarding your first job search and how that perspective changed in the beginning years of your career?
So during my fellowship, I was able to, I went to Toronto and I think that's going to, you know, in line of, you know, looking for good mentors, good, you know, the spirit of surgery and the different types of approaches. You know, John Adler, who went with stereotactic radiosurgery, right, which is not, you know, you're not using a scalpel for that, right? Robert Spetzler, who is doing the most technical operations under the microscope in the depth of the brain. And what I saw during my 4th year of residency was that what was really kind of standing room only type of talks at the meetings were functional. And one was Dr. Andres Lozano, and he's at University of Toronto. And so that's where I went. And he was doing a lot of work with depression. And he had just finished his phase 1 trial with Alzheimer's. We're currently in a phase 3 trial looking at deep brain stimulation for Alzheimer's. He just finished his early work with that when I got there. And my experience when I went there, you know, deep brain stimulation is an operation that's done awake. You have a scientist in there kind of mapping out the cells, and it can take all day basically. And so what I saw when I went there, and because it's an awake brain surgery, you know, who is it for, right? Is it a treatment of last resort? Is it, you know, is it an experiment that you're doing? You know, because a lot of research is being done in those operating rooms. I saw a huge opportunity to kind of streamline the operation and make moves toward making it something that's more readily accepted because the data is out there. The data for deep brain stimulation says it's not a treatment of last resort. You know, there's a very, very clear time point at which it's going to give a boost to quality of life for patients with Parkinson's and tremor. And so, you know, you look at the setting and you see why patients aren't signing up for this, why neurologists aren't referring patients to this, and that this can change, you know, that this can be something that, you know, what's the path, right? From where we are today, where we were 10 years ago, to where we might be in 2050, where, say, because of neurodegenerative diseases, 15% of people are candidates for some kind of, you know, brain chip, right? Whether it be for memory, for Parkinson's, for obesity. And what's the path there? Well, you gotta really standardize this operation. You know, when you're run-of-the-mill patient, it can't be an experiment. It's got to be just right? Get you in, get you out, get you back in the game. And kind of seeing the workflow that was present during my fellowship, which is very similar to how it was in the 80s or the 90s and the 2000s. I saw an opportunity kind of put BNI, the Barrow Neurological Institute, ethos of surgery into DBS. And so my experience in fellowship kind of motivated me to see the opportunity to kind of build a volume in this subspecialty beyond what was currently assumed could be possible, both by streamlining the operation, making it more efficient, engaging with neurologists, educating patients, and providing a very consistent, predictable result with the surgical outcomes, so that the click would happen, that people would realize that they're choosing not to improve their life if they choose not to have surgery. That surgeries that basically, think about the situation where if you think Parkinson's, what's the shift that takes place when people think Parkinson's? Surgical disorder. You think brain tumor, right? You need surgery, right? If you have Parkinson's, I need a brain pacemaker, right? There's a shift, and the events have been taking place since early 90s, going in that direction. And I think that I got the sense that there was kind of a stall that was taking place in terms of the advancement of this. And using that platform of things like tremor and Parkinson's, we can use that safety and efficacy to learn more about the brain and take the next incremental steps, targeting things like Alzheimer's, appetite disorders, mood disorders. So that was kind of that's kind of where I went when I kind of jumped from training, having, seen the Spetzler way of doing things, worked with one of the most, innovative thinkers, in the field with Dr. Andres Lozano, and then, having the opportunity to kind of do my own thing after residency. The first job, the options are always, do you do private practice? Where do you end up? A lot of academic medical centers really kind of are looking at sort of that surgeon scientist, having a lab, having 50% of your time dedicated to research, 50% toward clinical. And like a lot of people point out, a lot of what job you get is a matter of timing, right? There's only so much room for a tumor surgeon or an aneurysm surgeon or a DBS surgeon. And the timing was such that the Barrow had been looking for somebody to kind of represent in the functional stage, like we've traditionally been represented with tumors, with aneurysms, with spine, and have and they had the resources to invest in that. And so in some ways, rather than learning the Barrow magic and taking it somewhere else after my residency, while I was at the Barrow, I went somewhere else, learned the magic there, the skill set, the niche, and brought it back to Phoenix, Arizona. And so I was positioned both because they were still looking and because I had the training, right place, right time, right subspecialty, to get a position at Barrow, and where it was sort of where I'd specialize in functional neurosurgery, have the opportunity to continue kind of a general practice with general call, and initiate an academic practice as well.
What would you say were some of the keys of your success that shaped your early career as you climbed the top of your industry?
I had a really dynamic neurologist that I partnered with early on, and I also did not have a senior. We had other surgeons in my subspecialty, but not as sort of owning that kind of that section within our department. So I was kind of able to kind of start off in charge of that section, the stereotactic functional section of our group. So starting out a residency, not really having somebody I had to necessarily defer to in my subspecialty, kind of having that ownership, and then having a partner who was open to new ways of doing things. Specifically, during my first year in practice, we made a shift from doing the traditional approach, which was an awake operation. We shifted to doing it under anesthesia, which made it a much faster and efficient operation, and predictable and more appealing for a patient. They don't want to be awake for surgery. And so that neurologist, who was subspecialty trained, fellowship trained in all the awake maneuvers, was open to considering changing the way we do the operation, which in effect had made the operation more accessible. I think if I had been in practice for 5 years, kind of doing it the old-fashioned way, I might not have had that same kind of flexibility mentally to try something new. I'm like, well, this works. I'm happy with my practice. I'm not hungry for, I'm not looking to like double my volume. And so I might have kind of become a creature of habit had I not had that chance to be exposed to that new way of doing it, and having the support with my partners in other areas in neurology to try that out. So we were able to kind of dip our toes in that 7 months into my practice, and then we ran with it, and then the rest was history, and we became the largest deep brain stimulation program in the country.
What advice do you have for graduating residents and fellows entering the professional job market for the first time?
I think be open to a range of opportunities and experiences, see what sticks. When I first started, I made many attempts to kind of start a lab, get basic science work, and that didn't take traction when, meanwhile, the clinical part really took off. It's not like I started being like, I want to be the highest volume DBS surgeon in the country. That was actually my intent. I wanted to build a program. But then when we started doing a sleep surgery, all of a sudden the volume grew. The opportunity came to participate in the phase 2 trial of Alzheimer's. But that's not what I started off saying. This is going to be my area of focus. It's a zero-sum game, right? Whether you're traveling for organized neurosurgery, if you're working in a laboratory, if you're writing clinical papers, you're teaching residents and family, right? What you do outside of the hospital. It's, I think more and more you're going to see, neurosurgeons who have real interests outside, have a balanced life, the work-life balance. So it is a zero-sum game. But what I encourage graduates is find a way to contribute to the field beyond just that doctor-patient relationship. There's something. You don't have to be at university. You don't necessarily have to be at a residency. It's teaching makes it not just a job. It's one of my biggest joys is being able to teach residents, and it's a real privilege to be an educator like that. But not everyone's going to end up in a residency program. So if you're not in a residency program, you're not. There's some way to make an impact in the field. And the thing about being a doctor is, with that experience with the patient in the clinic, in the operating room, that's almost enough. I mean, it's incredibly gratifying. You come home at the end of the day, you started and finished 1, 2, 3, 4 operations. So you've actually done something kind of finite, but you've completed it. So it's easy to kind of be like, this is enough. I've got my family, I've got my, whatever, like to do this sport, and I've got this great job that gives me a lot of fulfillment. And I think that sort of charge, especially, kind of when you've had amazing mentors and you've been at amazing programs and you've had this amazing, pedigree education, paying it forward. How do you pay it forward? And I think that there's many ways to do that, and to kind of keep your eyes open, looking for those opportunities to pay it forward in not necessarily, your traditional conventional ways of, residency and research, but to strive for something beyond just that patient-doctor relationship that is really the core of our day-to-day responsibility and mission. Another thing I often tell residents, when, again, there's only so many jobs for aneurysms, for tumors. One thing I read in an editorial when I was in residency was find what nobody wants to do and make it yours. And it can be so pithy, but it's like, for example, pain neurosurgery, like pain. People just like stay away from that. No one's doing it. Go right. That's what I did. No Barrow resident was going into functional. They weren't doing deep brain stimulation. And I'm like, you know what? I'm going to make this mine. I'm going to own it. And then a couple years after me, one of our junior associates graduated and had a real interest in the lab. And I said, go for pain, make it pain. It's wide open, and nobody's doing it. And so, in neurosurgery, everybody's flocking to spine, right? Spine is becoming almost a commodity. They're doing it at, it's strip malls, right? Strip mall surgery at these ambulatory surgery centers. And so the competition is so fierce for somebody because as it becomes a commodity. And so I think one approach is, is to find that one area, find those areas that are underrepresented, own it, make it yours. And there's that pride of ownership that results from it, no matter what it looked like from the perspective of the resident who's always trying to get into the tumors and aneurysms. Once you get in practice, it's a completely different shift. And once it becomes your practice, that pride of ownership supersedes so many other aspects of what the surgery entails.
With all your experience in the operating room and understanding that there is a human element to being a surgeon, what type of advice would you have given your younger self when dealing with possible complications during cases?
That's a great question. I think that one of the appeals of neurosurgery, of medicine and surgery itself, it's sort of like the experience, and this is it's like people who sign up to be a soldier. That's a totally different level of service and risk. And like we've talked about before, it's medicine is not a very high risk path, right? It's a very safe path. You get to be a doctor, and there's very little that as long as you can get the A, right, and you can score well on the tests, you can become a doctor. Like there's not much subjectivity in that path. But people look for that experience, right? It's the elevating experience that you discover wisdom through, and you discover something about humanity through, and being at the patient bedside during death and dying will teach you something about life, and I think and same thing with the grind of residency, right? It's putting yourself through the worst years, your best years you'd never want to repeat. It's always called the second year of residency, and the transformative experience. So that being said, when you get those complications, people try to, not everybody handles those the same way. Some people want to, walk the walk and act like it's not a big deal, and other people feel crushed by it. And I think that some of the best surgeons, when you see. I often joke that life-saving surgery is overrated, because with life-saving surgery, the most dangerous operations, you win some, you lose some. Even in the best of hands, you're going to get devastating complications the higher you go in terms of complexity. And those surgeons who've committed themselves to that craft at those the higher levels of morbidity, they've got to show up the next day. But that journey to becoming that surgeon who can show up the next day, it's not easy, right? It does a number on your soul. And so when you get those complications, soak them in. Don't forget about the patient. When it's when the patient's in intensive care unit, there can be almost this force field outside that room when you go around, and you just want to put your head down and keep walking, and you got to break through that force field and just go to their side and talk to the family, engage with them, and really soak it up, and be there for the patient, and don't bury it, while at the same time processing that experience, knowing that the right thing to do is to show up the next day and give it your best shot all over again.
We hope you enjoyed this episode of Interview with the Surgeon. Until next time, stay focused and keep following your dreams.